to introduce our panelists, Dr. David Sachs from the Seidenberg School of Computer Sciences and Information Systems, and Doctors Lynn Drury and Dr. Sharon Wexler from the College of Health Professions. Today, we'll hear more about the work that they're doing with new and remote technology. Dr. Sachs is currently involved in a large 6-year telehealth project called TIPS, which stands for the Telehealth Intervention Programs for Seniors. That's been funded by the Weinberg Foundation and Fannie Mae and other funding resources for our Westchester community and beyond. Dr. Sachs, could you tell us more about what TIPS is and how it all started?
Sure. Good afternoon, everybody. Nice to see you here. The TIPS program is interesting. It's a real good example of how a faculty member in a university can start with an idea, and then that idea can grow and prosper. Jean Coppola was a longtime faculty member in the Seidenberg School, and in 2013, her idea was that students should be involved in service learning, and she was particularly interested in working with seniors. And so her idea, which was a fairly simple one at the time, was that the students should go to a senior center located right near the New York City campus. And several days a week, they would show up and they would take vital signs from the seniors. They would do blood pressure, pulse, oxygen, and weight. And the theory was that if you could get to people who didn't have a lot of money and who normally did not have much of a chance to go to a doctor, you might be able to forestall visits to an emergency room, visits to a hospital, whatever. So Jean started with this idea in 2013. And sometime during that year, we learned about the fact that New York City was going to be offering $1 million. This was when Michael Bloomberg was still the mayor of New York City. And Jean was excited about that. I had no idea what she was talking about, but I had written a number of grants and been successful. And I said, well, I'll help you. What's the worst that could happen? So we wrote a grant, so did about 100 other entities. And we were lucky enough and fortunate enough to get one of these $100,000 grants. And that grant meant that we could suddenly have this same idea of taking vital signs in about 5 different locations. And then the following year, we got word that the Weinberg Foundation was interested in what we were doing. And that led to literally millions of dollars of funding. And we were able to offer the TIPS program in 18 different sites in Pennsylvania, New Jersey, Connecticut, and in New York. The TIPS program is still being offered today. And it's basically, if you were going to try to look it up online, what you would find is that it's a good example of what the industry calls remote patient monitoring. We send college kids out to either senior centers or to congregate living locations. And once or twice a week, they will be there. And as a good friend and colleague of mine said, you know, they come for the TIPS program, but then they stay for the really cute college kids because it reminds them of their grandchildren or their nice kids to talk to. We work with Westchester County heavily and provide a whole array of social service wraparound services. So the people come, the actual remote patient monitoring takes maybe 5 or 6 minutes, but people often come an hour early, they stay an hour or 2 later. So it's really been an interesting project. I think it's been great for our students. We have Pace University students involved. We have students from other colleges involved. And what happens is once the data is collected, it goes via Bluetooth technology to a tablet and from there to a server. And once it gets there, a nurse has access to a dashboard and the nurse can look at the data and it's all programmed using a highly sophisticated system of red, green, and yellow. And if it's red, that says there's an alert and the nurse will pick up the phone and call the people involved. and suggest perhaps that they get to a doctor sooner rather than later. A lot of the issues that we see, high blood pressure is a big one. Sometimes changes in weight are big. And sometimes it's things with all the COVID that's been underway. Sometimes it's oxygen levels that are a real issue. And so it's not intended to be an emergency room. It's not intended to be a hospital. But the real goal is to give people access to um, low level, low key information that can keep them out of a hospital or out of an emergency room. And we've got all sorts of statistics to say that we've been doing a pretty good job of that. So that may be enough for the moment. I know we've got questions, but that's kind of what we're doing. If any of you wants to know more, I'm sure that Michelle and others will be glad to share my email, and I can give you some websites and videos to look at and all that good stuff.
Thank you so much, Dr. Sachs. Thank you so much for the overview of tips and sharing some of the work that PACE and the community is doing in remote patient monitoring. Dr. Drury and Dr. Wexler, you're both professors in the Leonhardt School of Nursing in the College of Health Professions, and your research is focused on AI, which stands for artificial intelligence, of course, and robotics as they can assist seniors. Could you elaborate a little bit further on some of your work that you're doing in the community in your research?
Sure. And Lynn, jump in at any point. So our program of research got started in kind of a very similar way as what Dr. Sachs described. We also partnered with the late Jean Coppola, and we started back in 2010. And as nursing faculty, we had always been involved caring for seniors in the community. But back in 2010, we started to notice that our seniors had a real interest in learning something about computers. So we started very slow. Initially, Jean Coppola's students refurbished old computers that Jean found around the university and schlepped them out to individuals' homes, retirement communities, assisted living, nursing homes, you name it. And Lynn and I had students in those different organizations. So Jean brought the computers, and the students installed them and taught the seniors how to use the computers. And we started to work with the seniors using the computers to reach out to family members, to look up health information, etc. We also were fortunate that same call for submission of proposals. We did submit and we did get funded. We got funded 2 or 3 years in a row, and we tried out a whole bunch of different technologies. After that, we started to get more involved, not just with the community. We realized that patients in hospitals, older adults in hospitals, had needs that were not being met as well. And a lot of it related to social isolation and loneliness. So we were fortunate. We also got funded from the National Institutes of Nursing Research, and we started to bring some of the tablet-based technology into the hospitals. And we realized that we could impact delirium, which is acute confusion, by giving the older adult a tablet. And delirium is a common cause of death for older adults in hospitals. It prolongs length of stay. It's a really serious outcome. So while we had that running, we also got involved in robotics. And Lynn, why don't you tell a little bit about the robotic piece?
Yeah, the robotics piece was especially interesting because one of the things that we discovered in working with clients in the community and in the hospital was that internet access was a huge barrier for many of the folks that we dealt with. We specialized in vulnerable populations and institutions that served underserved communities. So financial issues were a major thing for most of the clients we were attempting to serve. So we could carry any kind of technology we wanted to into their home or into their hospital. And it didn't necessarily work because the internet access wasn't there, and either the facility couldn't manage digit or the individual if they were living alone in public housing, for example, which was a big part of my population. The choice between food, medicine, and internet, was a no-brainer. Nobody was going to pay for internet access when they didn't have enough money for anything else. So I began looking for technologies that didn't require internet access and found robotics, simple robotics that operate with nothing but flashlight batteries, and yet are quite responsive because they're covered with sensors, quite responsive to interaction with the clients that they are intended to serve. So I don't know if I should show them now or show them later. What do you think, Sharon?
Show them now. They're adorable.
They are adorable. And if we were in person, you would have the opportunity right now to hold and cuddle my favorite robots, and see and hear how they actually respond to the clients that we give them to. They are very cuddly, and they can do things like roll over and lick their paw. They will lay beside you and purr. They will wag their tail if it's the dog. Let me show you the dog. I also have a dog here in my home who is finding these critters exceptionally interesting. So this is our Labrador Retriever, and it's speaking to you now. The interesting thing about these is that the more you interact with it, the more it responds to you. So for example, if you have the cat on your lap, the entire time the cat is on your lap, it will continue to do things like roll over, lick its paw, purr for you, what have you. The dog, for example, if you put it in your office and are gone for the weekend, when you come back on Monday, the dog will whip its head up at you and go woof and say hello. So they are very responsive, and the people that we have placed with robots have found them to interfere with loneliness and depression. And there he goes rolling over for you. Let me show you that if you can see it. The tuxedo cat is our favorite. They also come in a whole variety of different shapes and sizes and colors, just like real cats. Right now, the dog only comes as the Labrador Retriever.
No, there's one new one.
New dog? What's the new dog?
It looks like some sort of spaniel.
Ah, okay.
I just saw it, I think, a couple of weeks ago. These robots are available to the public. The ones we use for our studies do have a little bit more technology in them. They imprint via voice, so as well as they have more sensors. We've done research on as far as faculty, we all love them. We all want them. But
our
as
dean has one.
Our dean has one. We figured if we were looking for research money from her at some point, it didn't hurt if she had this cute little robot in her office. But we've done research on them in both the hospital and in the community. In the hospital, we found that they decreased loneliness, and that they helped form a stronger connection with the nursing staff. Patients reported that nurses spent more time, or they perceived nurses spent more time. We actually did a time motion study. The nurses didn't spend any additional time with the patients, but the patients perceived the nurses spent more time with them because there was a connection. The nurse would come in, talk to the patient, and say, "Oh my, look at that adorable cat you have, or dog," etc. We've studied them in the community. In the hospital, by the way, we found patients fell less if they had a robot, which is kind of odd because the robot isn't doing anything to prevent falls, but we realized that we hypothesize that it keeps the patient occupied. And having worked with older adults my entire career, I think sometimes patients fall because they're lonely. They don't see anybody. They wonder what's happening out in the hall. What mysterious things are going on at the nurse's station.
I hear voices out there. Something's going on. I better go check it out.
And it really has made a difference. One of actually the first PhD graduate from our brand new nursing PhD program, who graduated a few weeks ago, did a study using our robotic pets and looked at the impact of the robots on frailty and loneliness during the COVID pandemic. So we've just really started. Every time we use the robots in a study, we think of 10 future studies.
Right.
So they've really shown some quite promising results.
And
Sharon?
people don't think of them as a toy, and they don't think of them as in any way demeaning. It's one of the things that we were concerned about when we started bringing them into hospital and putting them in bed with people. We thought, oh, people are going to go, no, I don't want that toy. Nobody says that.
Right.
Everybody loves them. Everybody keeps them turned on, and they know it's not real, but they don't care.
Right.
How expensive are they?
About $100 each on
$100.
the open market.
Yeah.
That doesn't seem like a lot of money given
Precisely.
given what you're describing.
Yes.
No, it's well worth it.
That's really nice. I think what's really nice about what that does is it gives that personal connection to the older adult without having all the real life responsibilities of a live animal, and all that real life care that needs to be done. When people maybe might not be able to, this gives them an opportunity to have that personal connection there. Thank you so much for sharing some of that work with us. I think one of the nice things that kind of tie into a lot of this great academic work and research that's being done in the community is really a person-centric approach to healthcare, which I see a lot of needs for, not just looking at one aspect of their health, but as Dr. Sachs mentioned as well, the social services that are wrapped around the person as well, and their behavioral health needs and other different things. It's really important to look at the whole person and not just one aspect of their care, because oftentimes one thing leads to the other and it's all impacted on the person-centric kind of care that's given. I wanted to shift a little bit to a topic which we're all affected by, which is the pandemic. And I just wanted to start with Dr. Sachs. I'm just curious, as we all are probably, how the pandemic has impacted your programs and research, especially knowing the history of TIPS really being in a community level side. How has the pandemic affected where TIPS is moving forward? How has it responded to the pandemic?
Great question, Chris. As you all know, the pandemic came along in 2019. And in fact, the date in my mind when I was last on campus with a class of students was March 9th of that year. And the TIPS program was running really well up until March 9th. And suddenly everything in sight was closing down. The university closed down, students were going home. But meanwhile, we had all these seniors in all these locations who were accustomed to being involved in a program that they thought was important and that they look forward to. So I think the word that came up over and over and over was pivot. And we had, in effect, emergency meetings to say, okay, what do we do with all these seniors who, if they ever needed healthcare, if they ever needed support, if they ever needed somebody to talk to, probably your robotic pets would have helped, but now would be the time. So we got all of our technical assistants. These are the students who normally would go to the various locations, and we got them all together using good old Zoom because that's what everybody was doing. And we said, okay, plan B. You're going to start to make phone calls, lots and lots of phone calls, because these same people who were used to seeing you once or twice a week still want to see you, only you can't go there or they're not coming to the centers. So plan B was TIPS in Touch. We made up a new name. We commissioned all the students to make calls. We have, as part of our weekly interactions, we have 5 questions that we typically ask the seniors. Nothing profound, but it's like, how are you doing? Are you still taking your meds? Has anything changed? Things like that. So they made all the calls and they took notes and they engaged the seniors. And suddenly we had a lot of phone calls going on. And again, because part of it was, well, if there's an issue, we still had nurses ready to be of help, but they obviously all weren't in the same place anymore, but we entered the data and the nurse was able to follow up. It probably wasn't as efficient or effective as it had been before, but it was a whole lot better than doing nothing. And interestingly, the students reported lots of great conversations. It was sometimes hard to get people off the phone. It's the same thing, Lynn, that you and Sharon are talking about. You know, it's the engagement, it's the involvement, it's somebody who's here to talk to me or somebody I can pet or roll over or whatever. So that was our phase 2, and we pivoted to that phase. And we not only do we have sites in Westchester, but we also have a big TIPS location in Newark, New Jersey, and we did the same thing there. So we kept everybody engaged, and we kept saying, this is pretty good. Well, then it became clear that what people were worried about were oxygen levels. And if you read the literature, there's a lot of good literature that talks about the fact that if oxygen level becomes a problem, meaning with your pulse oximeter gadget, and suddenly you're not getting the amount of oxygen you should be, that could be a good warning sign that you might be headed towards getting COVID-19. So we quickly bought, the pulse oxes are inexpensive, 20 or 30 bucks or whatever it is, but it's not a lot of money. So we bought, I don't know, 100 or 200 of them and gave them out to people and said, okay, when these kids call you, they're also going to ask you about your oxygen level, because if there's something going on, it's not 100% accurate because it's self-reported, et cetera, but better than nothing. So phase 3, if you will, or 2, or whatever the number is, phase 3, I guess, was that we would have some degree of support at home. We even got some of the seniors blood pressure cuffs as well. But again, a lot of it, we were doing it on the fly and we were doing it to help people. It probably wasn't perfect. Well, finally, we pivoted yet again. And the question was, what if you could give people a whole set of hardware and software that would be user-friendly, that would have, Lynn, I was thinking about your comment about the wireless network or the lack of networks. So we said it has to have a network. It's got to be self-contained. It's got to be real easy. It's got to be friendly, supportive, whatever. And so we worked, actually, we worked closely with Chris's brother, Dave, as part of Vital Care. Came up, if I could show it to you, it looks like a very small suitcase or a briefcase. And inside is a blood pressure cuff, a pulse ox, a scale, and a small tablet. And so we weren't able to afford enough of those for everybody, but we did give them, we have lots of really good data on which one of our TIPS participants might need more help than others. We were able to give them out initially to about 25 individuals. And then last year, through Westchester County, we had enough funds that we were able to give out another 80. So it's been an interesting year and a half, interesting in quotes, I suppose, but the word pivot came up over and over again. And really everybody was scrambling to try to take good care of these seniors who very much wanted to see us and the students wanted to see them, but it wasn't going to happen. I'm pleased to report that a number of the senior centers in Westchester are opening or in the process of opening. Our center in Newark, and Newark's been really hard hit with COVID, but we've managed to work closely with people there. So far, we're still having outdoor meetings, but a week or so ago, we had close to 50 people show up. Usually we get more like 100, but people are starting to find their way back. I think there's a lot of pent-up demand on many levels with people. They want the social interactions. They want to feel safe and healthy, and this gives them some degree of some control over that part of their lives. So it's been a fascinating year in ways that none of us could have predicted or expected. And I think we've done as well as we could given the circumstances.
That's right, and having a place for them to go. We had the TIPS program had connected so many people, and obviously with the pandemic, people have routine, and after years of coming in person, they needed somewhere to go. So thank you
Oh,
for
yeah.
sharing how TIPS really pivoted to still give them care and ultimately activate them to take their own initiative in their health, which thousands of people have done. Dr. Drury and Dr. Wexler, how has the pandemic impacted your programs in the last
Well,
year and a half or so?
our inpatient programs, we do most of our work at Jamaica Hospital Medical Center, which is a safety net hospital. And unfortunately, Jamaica was one of the hardest hit during the pandemic. So we basically stopped our research during the pandemic here. The hospital was at, one
Every
had
unit was a COVID unit.
every single unit was a COVID unit. And we do all of our work using undergraduate and graduate students. So we had to pull out of the hospital. So instead, we focused on the community. We utilized our nursing students who were desperately looking for clinical experiences, or we were desperately looking for clinical experiences for them. So we did a lot similar to what David spoke about. We did a lot of outreach via the telephone. So we went out to all of our community partners. We partner with the naturally occurring retirement communities in New York City. Usually we're boots on the ground. We became virtual, and the students hooked up with the seniors. Lynn devised a very comprehensive script that our students used that really was linked to an assessment, and covered some very basic things similar to what you spoke about, David, but also, what kind of food, get up, go look in the refrigerator, tell me what's on the top shelf of your refrigerator.
How many pills are left in your bottle? Are you going to be able to refill your prescription? Do you have money? Is anybody available to walk your dog? How are you handling that? When's the last time you've been out of the house? Do you have masks?
Yeah.
All those kind of things. And we really basically, instead of having very strict criteria of how we distributed our robotic pets, any community, any group we could get to, if you wanted a robotic pet and we had one to give you, we gave it to you. So we
They got
had
distributed through Meals on Wheels. Henry Street has a big Meals on Wheels program, and we were able to get some pets into people's hands along with their lunch.
Right. And for some of the patients being discharged from the hospitals, we had one of our students, one of our PhD students was part of a director of a transitional care program. So as the patients were being discharged from the hospital, she reached out to them and brought them a pet. So we at least felt good in that we weren't doing much as far as our research was going, but we were serving the community. So we are starting to get back somewhat to normal. I'm at Jamaica Hospital today, and the numbers are really of COVID patients are significantly lower than they've been in a very long time. So we are looking at, re-energizing our research projects and rolling them out. The staff, the nursing staff in particular, are really, every time I see a nurse, it's, oh, when are we going to do your project again? So they're really looking, they see a value for the work that we do.
It sounds
That's great. Please, thank you. Thank you so much for sharing how the pandemic has affected your programs. And I just thank you everyone for that submitting questions so far. Just a reminder, as you have any questions or you just want to write it down, please enter it into the chat. We're seeing a few come in, so thank you so much for that. There's really great developments that are shared with us today. I think there's a real sense of that the pandemic has fast-tracked some of the telehealth and remote technology for healthcare.
Yeah.
I know for a fact, a lot of what we've been talking about today is especially older adults, but all of us being able to do virtual visits with your provider. Many of the people in this meeting, I probably have done one, or at least I've heard of someone that's done one. Whereas, even 5, 10 years ago, that was a lot less common. So this third question, as we're kind of wrapping through here, is just talking a little bit of how the panelists believe that these changes are affecting the average person, people like all of us, the common healthcare consumer. How does it change for us moving forward as far as connectivity to your provider? I would like to start with Dr. Wexler, if that's okay, for this one, this question.
I think it's really opened up a lot of possibilities. And I think even for groups of patients that we didn't think would embrace the technology. So when we first started, when Lynn and I first started working with technology and seniors, everyone told us we were crazy. And we were crazy because everybody knew seniors didn't know how to use computers. They didn't want computers, and we were barking up the wrong tree. One major foundation told us that we were 5 years ahead of ourselves, whatever that meant. P.S. We didn't get any money from him. At that point, we did get money from him later, from the program officer. But I think we really, when we envisioned, using remote technology, we didn't envision seniors really embracing it as much as they did. And they really
especially
have.
the seniors that didn't necessarily have English as a first language and weren't accustomed to using technology, hadn't been working in a white collar job where a computer was part of their daily life. That was a particular group that people thought we were really, really nuts for trying to get connected. And yet, once they had the opportunity to do that with a little bit of student support, and oftentimes it was just a little bit of student support, they were not only absolutely fine with it, they were calling me up at 3 o'clock in the morning if their internet went down to tell me that they were communicating, doing poetry with their relatives in Russia, and the thing went black, and now what?
Right. It's so important to have the technology easy to use. So I believe through these changes over the past few years and the pandemic push to do things more openly virtual has really opened up a lot of things. And as Dr. Sachs mentioned, a lot of, and as well as the other, older adults, it has to be a perfect marriage of something that's very easy to use on a user experience level. Obviously, for the providers as well, it has to work into their workflow, so we're not bombarding with all this data that's being collected, bombarding providers that are already busy with their regular jobs outside of technology, so to speak. And then also has to be meaningful for the person. And I think we kind of touched upon that all today, talking about how technology in a broad perspective can really help people be engaged with their provider, as I mentioned before, being activated in your health. And because the truth is, a lot of people probably don't put a personal importance on healthcare. In human behavior, it could be kind of pushed down as far as your in your list of priorities in your life. And healthcare and having more information on your health and being connected to your provider can certainly help that. And finally, Dr. Sachs, your thoughts on how this has been affecting how this is going to be affecting the average person moving forward in health technology in general, moving forward.
Again, I think that's a good question. I mean, it feels like for all the wrong reasons, meaning the last thing we wanted was to have a pandemic to deal with. Oh, and Ed Fitzgerald we'll get you in 1 second. It feels like it's changed everything. It's changed the way we go to school. It's changed the way students think about participating in classes. It changes the way we have a meeting like this. And I know I've just seen changes in attitudes. If you went to a meeting of the American Telemedicine Association, Lynn or Sharon, your number about being 5 years ahead of your time. 5 years ago, they were ranting and raving about how come nobody will accept a remote patient monitoring as a valid way to interact with a patient? So in effect, it was like you being told, no, you can't have any money only there were doctors there saying, I'm doing the same thing, only I'm doing it via an internet and blah, blah, blah. And basically what they were mad about is that there was no way to get, in effect, paid or reimbursed for the work they were doing. Well, if you show up today doing the same thing,
Now you get paid.
there's a whole set of codes. And so it's been interesting to watch. And I think what the pandemic has done is just accelerated things that they were in effect underway anyway. And suddenly nobody had time to talk to you about why it couldn't work. It was just, it is working. So I don't think what I'm telling you is maybe new news, but at least my own experience, I'm watching with students, I'm watching with doctors who didn't want to talk to you except in their office are suddenly happy to talk to you for 5 minutes using Zoom or the equivalent. And I think we're all living in that kind of change. So it's for all the wrong, terrible reasons, but I think that's what's happening. And
Those are all really great points, please.
Ed Fitzgerald, I saw a comment pop up. So
yeah,
Chris,
please. Yeah, that would be great. Ed, if you'd like to unmute yourself, we would love to
Sure.
briefly hear about, yeah.
Okay. Yeah, my wife was diagnosed with something called frontotemporal degeneration, an early onset dementia. It's about 10 years ago. And I looked for a way to use technology to help her. They went through a number of different attempts with a laptop and a desktop, and none of that worked. But eventually, I developed an approach to using the iPad with her, and didn't write any code, no new programs, but I did do research to find out what apps were out there that had been successfully used with people with dementia. And I pulled those apps together, and that became the core of what I developed over a period of time of apps and techniques and just ways that primarily she and I could use the iPad together. So when I would go to visit her in the facility that she was in, we would have something to do. It could be looking at pictures. It could be using the pottery app to create pottery. It could be using the drawing app to draw. It could be listening to books on tape. So I had two screens full of icons that that gave us a lot of choices, right. And it worked very successfully with her up to a point where she is now at the point where she's not aware of anything that's going on. But there were quite a few people in the facility that liked it, and I ended up going around and working with the Alzheimer's Association, doing a number of presentations, and it was generally well received, and it worked out well for us.
Right. Thank you so much, Ed, for sharing your experience. And that definitely helps resonate with a lot of people, because we've found through a lot of research, I know in my own professional experience, there's a certain level of comfort and interest. That's why I was mentioning before, I think finding something that interests the person, that's something that's really invested into the whole person of what their interests are and what their needs are, is a big key to success. If you just hand something that you think is beneficial to them without incorporating them into your research and your design, that's one common thing that these great professors in a lot of the research has done a lot of hypothesizing and testing and a lot of research to try to find out what will work for people, because it's truly a two-way conversation as far as how technology is developed and properly and successfully implemented into the field. So thank you for sharing, Ed. And with that, that's my segue into questions. Thank you so much for the panelists for sharing their experiences and their firsthand research. And right now, we're going to just kind of go through some of the questions and answer as many as we have time for. So one of the first questions I wanted to pose out to the group was related patient privacy. It's a great question on the patients. And the question is, do patients waive their HIPAA rights if they're involved in these programs? If not, how is health information collected and protected? So I'll open up to the panel if anyone has a question to talk about.
Encryption.
Mm-hmm.
Yeah, and in addition to encryption, we have databases where in effect everybody's de-identified. So we've got lots of people involved, but they have a number, and unless you've got and it's in another separate file in another location, and it's encrypted and all that good stuff. But unless you had that, you would have no way of knowing who the person is. We're very sensitive to that.
And the students have been trained as research assistants, so they go through the same sort of human subjects protection protocols that faculty and healthcare providers go through.
Right. Thank you so much for sharing your insight on that. It's a very important topic. The next question was just related for Maria. Is the research that each faculty member is discussing a clinical trial or something else? Just a little bit more background onto some of the research. Is it a clinical trial or study, or what type of research?
There have been a number of studies that we've been involved in. I wouldn't call any of them a clinical trial as such, although the larger studies have control groups that don't receive the equipment and get the same, battery of questions, instruments, research tools administered to them as those who do. So there's a comparison between what happens to those who have the robot, for example, while they're in the hospital, and those who don't have the robot while they're in the hospital. And we measure their level of loneliness, we measure their level of depression, we measure their number of falls, and have continuous conversations with both the clients with the robots and without the robots, so that we know that our interaction with the client is not an additional variable that might be skewing the results.
Yeah, and I would say probably a similar answer. I mean, if you're technical about a clinical trial, then you talk about double blind, you talk about
Right.
random selection. There's a whole set of things that go into it. In our case, we've been offering services. I mean, the TIPS stands for Telehealth Intervention Programs for Seniors. Our goal is to give away these services. So early on, we talked about having, quote, research in the sense of a control group, but that would mean that you'd be denying people something that they might want. So we all felt terrible about that, and we didn't do that. More recently, what's happened, like in Westchester, where we had enough funds to have 80 of these kits with the blood pressure cuff, the pulse ox, the scale, et cetera, because we didn't have enough money for 800 of them. In a sense, we were able to say, well, we've got 80 people, but we've got 500 or 600 people in the program. So what we can do is, and it doesn't meet the technical definition of clinical research, but if you've got 500 or 600 people who don't have something and you've got 80 who do, you can certainly run a lot of numbers to see, are there differences? Are the differences significant, either in the formal classical sense of less than or equal to 95%, or more importantly, did you make a difference? We use something called the PAM, which is a patient activation measure.
Model. Yep.
And it's a really nice instrument. It's got 12 questions or 13, whatever it is. And it's either got 10 or 13, I guess. And what that does is we can give that to people to see to what extent, but what they mean by activated is to what extent do I feel in control of my healthcare in this case. So we've been able to do that. And then, like with these 80 people who now have this whole set of hardware, we're looking to see, do they feel any better because they've got the hardware? Have we made a difference in a good way where they say, oh, I can now take my blood pressure 5 times a week instead of once a week? And so I think your question is a good one. I would tell you, and it sounds like I'm in complete agreement with Sharon and Lynn, we're doing research. I wouldn't classify it as clinical research, only because that's way more beyond. But we've published papers and we're happy to share data, and we're very sensitive to HIPAA, privacy, confidentiality. So I feel proud of what we're doing, but I wouldn't classify it as clinical research.
Thank you
Is
for the
that-
question and thank you for the responses as well. The next one is just a comment with a question is from Irene. Thank you for for this presentation and now the needed outreach to the senior community. I know a few people who would benefit from these services. How can I connect them? It's just a general question. How can we connect seniors to these types of programs or any type of service for them?
I think it depends where they live, because we do have different programs in different places. Ultimately, I think if you ask Lynn or David, and I certainly would agree, we'd love if these programs became standard, standard of care, standard practice. But unfortunately, they aren't yet now. So I think it really depends on, where these folks are and what their needs are.
And the other thing that we're doing, yeah, I think you're exactly right, Sharon. I mean, part of it is geography at this point.
Right.
And the other part of it is money. We have 7 or 8 sites in Westchester right now, but I just spent the last month writing 2 more proposals for a lot of money. And if we can get it, well, we might be able to double that number. So, but if you said, well, that's fine, but I live in Queens, I would tell you, well, there's probably resources that we can refer you to, and we'd be glad to do that. Personally, I want to talk to Sharon and Lynn about the dog and the cat. But I think part of it is where things are located, but sometimes it may not be our exact program, but it may be something comparable. So again, I would say get to Michelle, let her know your question, and if we can share resources, we're certainly happy to do that.
That's exactly right. And for the general person, as healthcare technology is becoming more commonplace in healthcare, a good place to start as well is asking if it's related to you or your loved one's primary care provider or other different people to see if there's something specific to help guide you in the right direction, because I'm sure there's a lot of programs out there as well, depending on where the person lives and the resources available to them that could help them out as well. So that's good. The next question was regarding someone related to in the area of Brooklyn who's homebound, doesn't have any computer or different connections, has a doctor who comes occasionally who could use more coverage. This is related to different programs for that. So it's just a question for that geography, specifically in Brooklyn or just in general, how to connect someone to their provider in that kind of situation related to their lack of technology. I know a quick answer I can start with, and I'll pose it to the panel, is that cellular connection I see in the industry is becoming more and more standard. The coverage continues to get better. So I know, for example, in the TIPS program, these are cellular based kits, which have very good coverage for no matter where they are, with Wi-Fi connection options and things like that. So I just wanted to pose it to the group as far as anything we can relate to that question.
I agree with you, Chris. My own experience is connectivity is increasingly better. I would also tell you that for a lot of what we're talking about, they're not particularly high bandwidth, as they say, meaning it's small amounts of information. They don't require, you have to have some connectivity, but it doesn't have to be blazing speed. If you needed connectivity and didn't have it, for example, in several of the locations that we've gone into with the TIPS program, they didn't have any connectivity. Well, we went to AT&T and Verizon, and for about, you can buy a gadget. It's like a little, I don't know, it's maybe about 1 inch by 1 inch or 2 inches by 2 inches. Looks like a little tiny credit card. You can have your own internet connectivity, and then you pay about $25 or $30 a month, and now you've got internet. So sometimes there are solutions to things like that that are pretty straightforward to add to what you're doing. If you're talking about somebody who lives and is homebound but could use more coverage, I guess it would help, Sam. I don't know what you mean by more coverage. What, can you tell us what you mean?
You can feel free to unmute, Sandra, if you'd like, and elaborate further if you're able to, or use the chat, whatever you're most comfortable with. Let's see if I can unmute. Oh, go ahead. I'm sorry, you have to unmute. Let's see if I can unmute you there. Sandra, if you can just unmute, that would be great. Then we can hear you.
Okay, this is
There you go.
a friend from childhood who's homebound. She has two bad hips. She cannot leave her rent-controlled apartment, which has a few steps, unless someone comes in, an aide or a service with a wheelchair to take her to any kind of doctor's appointments. So I am an occasional caregiver for her. Doing things from making bank deposits to bringing her postage stamps, etc. A doctor comes in about once a month. She's very unhappy, and that doesn't really like the doctor, wanted to change. I looked into services, found that NYU in Brooklyn has a outreach program to seniors using nurse practitioners, but because of her mindset, and she likes to be in control of everything, a nurse practitioner to her was not a doctor, can't do anything, you know. Oh, my doctor does EKGs, you know. And so I would like to get her some more help or care. But, you know, and some of what you're talking about sounds very good. You know, there seems to be a great lack of local services, at least in her area.
There's a great lack of local services everywhere, and just managing the system is a huge barrier for many, many people, and technology
Right.
is not necessarily helping people over that particular barrier. The Department on Aging may sometimes.
Landline, that's it.
Uh-huh.
I mean, I've gotten her a cell phone. I've done a lot of things to try and help, but she's never set it up and
Yeah.
won't let me do so, etc.
I get
Wants
it.
a different one.
Uh-huh.
The
Department on Aging sometimes can make referrals.
Right.
And since she has a home visiting provider, that provider might be the key to the kingdom as far as getting other resources in there, because the person has to be certified, so to speak, for a particular level of need, for a particular level of services. And generally the provider can make that certification that makes other things available, because getting it paid for is always the critical.
Of course.
Yep.
A lot
Thank you,
of the
Sandra, for sharing.
community, one other
Sorry.
thing, I'm sorry. A lot of the
Please.
community-based services are delivered by advanced practice nurses, are delivered by nurse practitioners, et cetera. So I think you might hit a wall there with your friend as well, because if her, you know, perception is that a nurse practitioner is not as good as an MD, when in reality, a lot of her needs would be better
Yes,
met.
I understand that myself.
You know?
I've worked in healthcare.
Right.
I
So
used a nurse practitioner. So I understand, but persuading somebody who has her own ideas is sometimes difficult.
Absolutely.
correct.
Thank you.
Yes.
Thank you for your suggestion.
Oh, thank you for sharing your experience, Sandra. I'm just moving on to another question. Thank you, Maria. It's just a good question on, are people with cognitive impairments or issues allowed to participate in the studies? And if so, how is consent obtained from them? So as far as qualifications to be in these studies.
Of course, having cognitive impairment, you know, it depends on the level of cognitive impairment. Many individuals that have cognitive impairment do have the ability to give consent. There's a whole process that's been put forth by the American Geriatric Society on how to obtain consent from somebody who does have some cognitive impairment. If somebody has does not have decisional ability, they probably, at least community dwelling, do have some healthcare proxy or someone else who's already making decisions for them. So in that case, we would go to them, but there is a step-by-step procedure to determine whether someone has, the ability to give consent.
Thank you for that question. And the last one I have for now is just if asked by Susan, if there's any, it's just curious if there's been any research or programming for the kind of tech intervention for neurodiverse people or students, for example, autism spectrum, learning differences, etc.
We are currently working on the School of Nursing, has a large grant focused on disabilities. And we've called it visible and invisible disabilities. So, the physical disabilities, which are the visible, and the invisible, which might be, cognitive or developmental delays, et cetera. So one of our colleagues, for example, just recently did a study with service dogs and children with cerebral palsy. She just got funded to use our robotic pets. She's going to use robotic dogs and replicate a similar study. So we have we're starting to do work with disability and considering all different types of disability. So more to come, more to come.
That sounds exciting.
Yeah, we're very fortunate. We started focusing on, the curricular aspects to make sure that all of our nursing students are educated on how to deal with folks with disability. We're in the process of retrofitting all our simulation labs to make them appropriate for people who have visible and invisible disabilities. The standardized patients that we use to teach our students also are individuals. We're starting to use individuals with disabilities. We have a advisory board made up of individuals with disabilities or caregivers of individuals with disabilities. So we're with the disability end, we're just at the very beginning, but it looks really, really, really promising. And I'm expecting to see some really good stuff coming out in the future.
That's great, Sharon.
Thank you so much for sharing. I just wanted to, as we conclude this session, I just wanted to spend a special thank you for Dr. Drury, Dr. Sachs, Dr. Wexler for sharing your time and your expertise and a lot of the research that you're doing. I think everyone that was able to participate, just a reminder, this is being recorded and you'll be sent the link to view this at a future time as well. And I'm just very excited to see how technology is affecting our community, whether it be for yourself or a loved one. Hope you learned something new today. Thanks for all of you for joining us, and congratulations to those who are celebrating milestone reunions today. Thank you so much for joining us.
Thank you, Chris.
All right, take care, everyone.
Bye-bye.
Bye, everybody.